Dr. Yodi for the facilitation. Bonjour, Dr.
Do I have a nameplate? No, I don't. Okay. Thank you.
Welcome. Bonjour and hello. Welcome, honorable ministers, distinguished guests, ladies and gentlemen. Thank you for attending this critical meeting. Today we share with you the latest updates on the mpox crisis as the mpox crisis continues to unfold across the continent, and bring you critical insights from the IMB, Intergovernmental Negotiating Body, as they enter their second year of deliberations, working diligently to forge a global consensus on pandemic prevention, preparedness, and response, one we hope that you will all push to help us get done by December this year. A quick background: who am I? My name is Dr. Ayade Alakija. Many of you know me as Yodi or Dr. Yodi. I'm the board chair of FIND, and I'm Dr. Tedros, the World Health Organization's special envoy for the Access to COVID Tools Accelerator, and co-chair the principals group of this body. I'm also co-chair of the Impact Investment Initiative for Global Health, led by the G7. The rapid spread of Clade 2, Clade 1b, coupled with the lack of diagnostics around at the moment on mpox, means that we are walking blindly into a storm. I'm delighted today to be joined by Dr. Tedros. Lovely to see you all, leaders, the President, the RD, and also congratulate our new RD designate. Today we also have here with us experts from WHO Regional Office for Africa, experts Maria Van Kerkhove from Geneva, and Africa CDC, the Director General, my brother Jean Kaseya. It's wonderful to have you here. Ministers of Health from DRC, Burundi, and South Africa will be speaking to us today, as will the co-chair of the IMB. It has been exactly 2 weeks since a FEC was declared for mpox on 14th of August. And when the world talks about a 100-day mission, we must consider that this first period is critical for a response. But have we not already passed the 100 days? Have we not already passed the critical time? Is it not past time that we act, and that we act now, and that we act together? We understand that there are many things going on, re-vaccines, but I must also remind us here in Africa, as you heard excellently from the experts earlier today, that we are used to outbreaks, we are used to epidemics, and we deal with them so much better than the rest of the world. The world should be coming to you, my honorable ministers and friends, to learn, not telling us what to do. And so I'm hoping today we're going to hear from the experts around this table. We're going to hear from you, the ministers of health, who do the hard work, many of your technical teams who do the hard work around the world. That work you feed up to the global level, to Geneva, to my friends in Dr. Mike Ryan, DDG's team, to Maria and all of their teams, to the Director General. But really, the work is done by you, all of you around this room. So I'm hoping that over the next 90 minutes or so, we're going to get some serious work done. We're going to get some work done that will advance the mpox response around Africa, and we're going to get some work done that will ensure that the IMB gets done by December this year, with equity at its core and making sure that we truly are dealing with the people who are suffering the most, those who are most affected by these crises. So we're going to talk about a plan. We need input from member states. I understand that there's a plan being put together with colleagues both from WHO and Africa CDC. We need input from you as member states. We need a clear description of the agreed modalities for the implementation of these plans. And without further ado, as I close, I'm going to say that we as Africans must be masters of our own destiny, mistresses, as I see many female ministers here and many of my sister ministers, of our own destiny. As we break the old paradigms of being reliant on handouts from the global north and work for our own self-determination, we must also continue to play our own role in the multilateral system, contributing our unique perspectives on our voices. Critically, we must be clear on how we manage the dichotomy of regional and global cooperation without impinging upon national sovereignty, because indeed you all come from sovereign nations. Countries have sovereign rights which cannot be wrapped into regional bodies or wrapped into international bodies. We stand alone, even as we stand together. The lessons of COVID-19 have taught us that at the end of the day, negotiations for medical countermeasures and distribution is a very national affair. So as you ministers speak today, we must respect your sovereignty and find ways for regional cooperation without throwing away national rights, either to the global community or to regional bodies. This is a fine balancing act we must play, and we must play to find a balanced solution, since our very lives depend on it. I am now inviting Dr. Jean Kaseya, Director General of Africa CDC, Dr. Mashishido Rebecca Moeti, the Regional Director of WHO Afro, not quite emeritus, and Dr. Tedros Ghebreyesus, WHO Director General, to open the proceedings and lay the foundation for discussions that will unpack critical challenges and concerns on the mpox response, as well as an update on next steps in the IMB. Dr. Kaseya, my brother, over to you.
My sister, Dr. Ayuade, thank you so much for giving me this opportunity to address Their Excellencies, honorable ministers here present. Dr. Tedros, my brother, I have to call him my big brother, the Director General Africa CDC. Now, yesterday I heard that Dr. Moeti is Regional Director forever. I don't know if this title exists, but I will check with the legal people. I will start to call you. Colleagues, this is a great honor for me and a privilege to be with you and to address all of you about some critical issues that we are facing in Africa. This meeting is being held at a critical moment with the mpox declared as a public health emergency of continental security on the 13th of August by Africa CDC and public health emergency of international concern on 14th of August by WHO. The mpox disease is increasing over the past few months, and based on the data we collected from countries on the 27th August, we have 22,863 suspected cases and 622 deaths. You will see we are talking about confirmed cases, but we are not talking too much about it because we still have countries with a testing rate below 20%. And we still have countries facing a number of challenges in terms of quality and transportation of samples. It's also another area where we need to make a lot of effort. Excellencies, dear colleagues, we don't have one outbreak. We have multiple outbreaks in one. If you consider the number of clades that are circulating currently. And to give you an example, when in Europe they had to use tecovirimat to fight clade 2 in 2022-2023, a study conducted by INRB in DRC, NIH, and other key partners shows that tecovirimat is not effective, cannot support the response in Africa, especially in countries facing clade 1. Let me give you also a kind of background on the declaration of mpox as public health emergency of continental security, which was a historic milestone in the journey of Africa CDC. As you know, this is not just a political declaration. We had to follow, based on the Article 3, Paragraph E of Africa CDC statute, we had to consult a number of technical, strategical, and political people to make this declaration. We had a group of 16 African experts under what we call the Emergency Consultative Group who came together and advised the Director General of Africa CDC to declare based on data that were available. But let me remind you, because we need to be proud as Africans, out of 16 people, 7 of them are also members of the WHO Emergency Committee in Geneva. The declaration will enable us, as Africa, to mobilize resources across affected countries, but also high-risk countries. Because when we started to talk about it, we had only 7 countries. Today, we have 13 countries affected. You have to consider that all of you can be affected if we don't put in place strong measures to stop this outbreak. This is why we need to unlock funding. We need to unlock medical countermeasures. We need to strengthen the communication and community, risk communication and community engagement. We need to boost surveillance, and we need to make sure that we have the testing ability and human resources to proceed with this testing. We say that, we repeat it, mpox is a zoonotic disease. If there still are the people who are doubting to implement One Health approach, I hope and I think this is opportunity to say Africa needs One Health approach. Excellencies, colleagues, dear friends, please let me thank Dr. Tedros. Let me thank Dr. Tedros because even if WHO Geneva declared the public health emergency of international concern, but is letting Africa managing this outbreak. And let me tell you, we are coming together to manage this outbreak. Africa CDC is bringing the political and strategic mandate, and WHO at regional level is bringing the technical expertise. This is why we are co-creating for the first time, and this is historic in Africa, one continental incident management team. We are co-sharing this continental incident management team, Africa CDC WHO. It means countries will not be confused by seeing WHO and Africa CDC coming together, co-sharing this response. This is why also we decided to have one continental response plan. When we talk about one continental response plan, it means it's what we got from African country members, mostly affected by mpox, plus technical assistance from partners. Then we have one plan that will be presented to you. Dr. Mweti, my sister, and myself, we are on daily basis leading that. We are on daily basis in contact with Dr. Tedros for some strategic areas like procurement of vaccine. Let me share with you some good news. Today, we are moving towards securing almost 1 million doses out of the total we need. We managed to secure 215,000 doses from Bavaria Nordic in partnership with European Union under ERA. You saw me 3 days ago talking with the French State Minister to unlock these 100,000 doses from France, almost 100,000 doses from Germany, and yesterday I was talking with my sister, the Minister of Spain, about the 500,000 doses from Spain. We are moving because we cannot accept to see Africa lacking vaccine to respond to this outbreak. More than that, local manufacturing, we cannot stop it. We are still not prepared for another pandemic. This is why we clearly say to Bavaria Nordic, we need the tech transfer to African manufacturers. We started with 9 manufacturers. Currently, we have 1 selected based on the ability to manufacture vaccine. We believe that very soon, the mpox vaccine will be manufactured in Africa.
Excellent.
I can't stop without talking about the pandemic agreement. Ladies and gentlemen, we are talking about the next pandemic. We are thinking that it can come in the next 5-10 years. Mpox is a major alert for us. And we see we are not prepared. This is why we need to finalize the pandemic agreement. This is why we are calling our partners from Western countries to come to continue the positive engagement, and Africa CDC will be there to support all member states to finalize this agreement. I believe if we finalize the agreement, I believe if we move forward with the local manufacturing, I believe if we strengthen our surveillance, Africa can be secured. I thank you.
Thank you very much, Dr. Kaseya. Africa can be secure with the work of all of us, with the work, combined work. It's great to hear you talk about Africa managing its own part of the current emergency with political and strategic mandate of Africa CDC, and recognizing the technical expertise of WHO, who of course has staff in country offices all over the region. It's wonderful to talk about the one continental management team and also the vaccination doses. But I must also remind you all, as I hand over to Dr. Mweti, that we can't have another vaccine-based strategy. We must do primary health care. We must do the basic things. It is not just about vaccines. I look at my brother, Minister from Nigeria, Pate, and congratulate you on the 100,000 doses that were the first to arrive in Africa, which arrived in Nigeria in just a couple of past 2 days. Dr. Mweti, over to you.
Thank you. Thank you very much, my dear sister Yodi. So, honorable ministers, the Director General of WHO, my brother Dr. Tedros, Dr. Kaseya, the Africa CDC Director General, distinguished colleagues, friends, ladies and gentlemen. I'd like, on my part, to welcome you to this special briefing session on the mpox public health outbreak in Africa. And also, we'll be providing updates on the intergovernmental negotiating body, INB. I very much appreciate your interest in both. You know, if you look at the program of this regional committee, and I'll promise I didn't do that because it's my last regional committee, there were so many important issues to discuss. The program is very full. We have a side event every morning, at lunchtime, and every evening. But we thought, as we were finalizing the program, that the matter of this outbreak of mpox was so important that we had to change our initial idea of having it as a side event, squeezed into a break, and incorporated it into the main agenda as this special event, because we wanted to be sure that all the delegations would be free, all the partners would be available to be with us. And of course, we are very happy that we're able to do this jointly with our colleagues in the Africa CDC, because it is that important as an issue and as an illustration of all the efforts that we are making together to improve preparedness and response to epidemics, to pandemics on the African continent. I'd like to start on a positive note, just reflecting the discussion at the previous session, where we were able to demonstrate that if we invest strategically in certain capacities, and I was happy to hear this confirmation from the member states who took the floor in large numbers, which is why we are running late on our program, that you are starting to appreciate that investing in human capacities, investing in capacities to manage, analyze data and have information in real time, investing in ensuring that supplies are there on time, actually is making a difference. So I'd like to start by saying that we're facing a serious challenge with this outbreak, but we've already started to see a change in capacities in the countries, including having the surge capacity of experts that we are using to support responses within the countries and even to go internationally. So I'm hoping that we're taking this discussion in a very positive, increasingly self-confident note, indicating that we're facing big challenges, but we're doing things to address the capacity gaps on the continent, and working together, we can arrive at a point we'll be able to face up to pandemics. So thank you, just because I didn't speak at the end of the last session, for confirming that what we are doing to improve the capacities in countries is reflecting your needs, and we will work together with you, together with our colleagues at the Africa CDC and our headquarters to consolidate those capacities so that we can face up better to mpox and to other pandemics as they confront us. It's already been said that at the global level, WHO is leading efforts to combat the ongoing mpox public health emergency, which was declared by Dr. Tedros a couple of weeks ago. We're seeing, as my colleague said, different outbreaks take place in different places. So I'm hoping as well, because I'm an eternal optimist, that we can, while acknowledging the gravity of the situation, put the whole story into its perspective. You know, just before the start of the regional committee, I got a message from a leading person in public health who asked me, why are you convening an in-person regional committee in the face of this mpox? Why don't we have this meeting virtually? So first it was like, okay, we're going to elect the regional director. Very difficult to do virtually. But it was also forcing one to think about putting this into perspective. And as my colleague said, we have different disease outbreaks. We have the epicenter in the eastern part of the Democratic Republic of the Congo, and it has spread to Burundi and other countries. We have outbreaks having happened in other countries. We have endemic situations in a number of countries, and we have also leftovers of the global epidemic that happened in 2022 in some countries in Africa. So in my view, we need to work together to understand each of these situations and apply the appropriate responses as deserved, and then enable preparedness to be strengthened, border collaboration to be strengthened, systems to be put in place in case needed in the rest of the countries, and enable normal life to continue even as we mobilize a response to this pandemic. So that's very much my second message. I'd like also to share some information on the work that we are doing at the country and regional level in WHO, because after this, My boss, Dr. Tedros, is going to speak about the measures that are being taken at the global level to altogether help address the risk and the reality of this mpox outbreak. So we're focusing a lot of our response efforts in countries with confirmed mpox cases initially, taking proactive measures in high-risk countries within borders of affected areas. We think that this is a critical part of our strategy to prevent the virus's spread across borders and contain outbreaks before they spread and escalate. In the affected countries, we have been working very hard in developing mpox treatment guidelines and extensive training programs for healthcare workers focusing on the clinical management of mpox. These trainings go beyond providing basic care. They involve identifying, treating, and caring for patients, particularly managing severe cases and providing much needed psychological support to patients and their families. We learned during the COVID-19 pandemic how important that is, and it's an aspect that we need to incorporate into everything that we do as we help in the response to disease outbreaks. I'm very glad to say that we are leveraging COVID-19 capacities to scale up the mpox response. For instance, since the COVID-19, we now have all countries capable of carrying out PCR testing for mpox. And this week, we're collaborating with the Institut Pasteur in Dakar and WHO, the West African Health Organization, to conduct diagnostics and sequencing training for mpox. We've seen already in the response that there is a need to decentralize testing. So we are needing to look, we've been looking at technologies like GeneXpert, technologies that can be used at the peripheral level in addition to PCR, and we are working within countries through our country teams and the experts that we have deployed in countries to build and increase this capacity. We've supported our member states in operationalizing dedicated treatment centers and isolation units for patients to make sure that these are adequately staffed, monitored, and equipped. In addition to targeted efforts for affected member states, we're making comprehensive arrangements to make sure that every country, regardless of its current situation, is equipped with the necessary tools, knowledge, and support to respond effectively if the need arises. We all know that we must prioritize vaccines reaching those who are most vulnerable. We've been very much in the forefront of vaccine readiness and have developed an mpox vaccine introduction readiness assessment tool, which will ensure that we have targeted vaccine deployment plans. This readiness is critical as we engage with other partners to secure vaccines, and I'm sure that the Director General is going to share what he has done at his level to make sure that we are getting the vaccines that are needed. Cumulatively, our efforts are geared to ensure that our response is quick, scientifically sound, enabling us to detect, diagnose, and respond to mpox. At the regional level, the most vulnerable to public health emergencies, as this region is most vulnerable, has already been said, to public health emergencies, we know that this won't be the last time we deal with an outbreak of such proportions and of such risks, and we will continue to work on this. I'd just like to end by saying, as happened in the past outbreak, we are starting to see pushback in misinformation around mpox, including the need for vaccination, yes or no, and say that we had a very strong platform of addressing misinformation in the region during the COVID-19 pandemic, and we are restarting that work that we are doing, the infodemic response, to make sure that we gather the right information, we monitor the misinformation, and we provide the support to counteract it as much as possible. So I look forward very much to working with our colleagues in the Africa CDC within our joint emergencies action plan, and of course with the support of our headquarters, to help you, honorable ministers, to address the risk and the outbreaks within this mpox situation. Thank you.
Thank you very much, Dr. Moeti, for that comprehensive overview of what is being done at country level, at a practical, technical level. Of course, as board chair of FIND, which works with you all on diagnostics, I'm delighted to hear that diagnostics and testing is very much on the forefront of this response, and that you're actually actively working with African institutions to push this agenda. And without further ado, it is my honor and my privilege to welcome Dr. Tedros to give his remarks.
Thank you. Thank you, Yodi. Thank you so much. Honorable ministers, members of delegation, and my sister Shidi, and my brother John, dear colleagues and friends. Mpox is not new to our continent, and it's not new to WHO. For years, WHO has been supporting affected countries in our continent to respond to sporadic outbreaks of mpox. And for years, we have been calling for more research and for the development of diagnostics, therapeutics, and vaccines for mpox. We see now it's attracting the attention of the international community. As you know, 2 weeks ago, an emergency committee under the international health regulations and on its advice declared a public health emergency of international concern over the outbreaks of mpox in Africa. This is the highest level of alarm under international health law, as you know. My declaration is completely aligned with that made by my brother, John, the Africa CDC Director General, the previous day of a public health emergency of continental security. By the way, this is historic and done first time, and the continental and global declarations actually reinforce each other. John and I have spoken frequently to ensure our two organizations are working together closely to leverage our comparative advantages and to coordinate our work under one plan with one budget, as John had already indicated earlier. As a side note, I'm proud to say that I actually proposed the idea of establishing the Africa CDC at the Abuja African Union Summit in July 2013, when I was Minister of Foreign Affairs of Ethiopia. So I'm very glad to see how my daughter, the Africa CDC, has grown and is now co-leading the response to mpox with WHO. So from the proposal, it's 11 years, WHO is 76 years, now we are co-leading. And I'm really glad to see that. And credit also to all member states of the African Union for establishing the Africa CDC. And in accordance with the IHR, I issued temporary recommendations last Monday for countries at risk. And I have also extended the standing recommendations that I issued last year for all countries. On Friday last week, we shared our global strategic preparedness and response plan to stop human-to-human transmission and bring these outbreaks under control. And I am confident that mpox can be stopped if we work in unison under the leadership of you governments. On Friday, we received the information we needed from the manufacturers of both vaccines to evaluate their products for emergency use listing. We expect to be able to issue that listing within the next 3 weeks. In the meantime, I have given the green light to Gavi and UNICEF to proceed with procurement of vaccines pending the EUL decision. It's vital to stress that although vaccines are a powerful tool, they are by no means the only tool. There are many other things that WHO, the Africa CDC, and our partners are doing to stop outbreaks and save lives. And I think Shidi had already indicated and also shown some of the things we're doing, and I don't want to repeat that, but with test PCR missions, with supporting labs, scaling up workforce, and training health workers and supporting clinicians, working with local partners, civil society, and engaging affected communities, starting from the design, implementation, and so on, much more. And the last thing I would like to say is, the mpox outbreak is another reminder, if any were needed, of the critical need for a legally binding international agreement to ensure a coordinated and equitable response to pandemics. As I did in my opening remarks on Monday, I urge all member states of our continent to engage actively in the work of the International Negotiating Body, IMB, and to complete those negotiations by the end of this year. I thank you, and Yodi, back to you.
Thank you very much, Dr. Tedros, and congratulations on your daughter's coming of age. We are proud that you helped birth this baby and happy to see that the baby is now growing up into an adolescent. Dr. Tedros has just reminded us that mpox is not new to our continent. Dr. Tedros has just reminded us that it is only when it began to spread to the rest of the world that the world started to take notice. Dr. Tedros has reminded us that the tools are available, but they're not always available for us. Dr. Tedros has reminded you, Your Excellencies, that you have an incredibly critical role to play, not only in stopping this current outbreak, which we can and must stop, but also in ensuring, as my dear sister Precious Matsoso, the co-chair of the IMB, will speak to later, that we have a clear and binding pandemic agreement by the end of this year, I add. And so, having heard from what we call in Nigeria the ogas at the top, I will now take you to my colleagues who are going to give us a technical update on mpox. We're going to hear from WHO and Africa CDC, this wonderful partnership, about preparing, detecting, and responding, a blueprint for tackling mpox. Dr. Maria van Kerkhove is the Global Mpox Incident Manager. She is the lead person in Geneva in charge of corralling us for the ACT Accelerator. A dear sister, a dear friend. Maria, I welcome you.
Good afternoon, colleagues, excellencies, Director General, RD, DG of Africa CDC. It's a pleasure to speak with you today. If I could ask for the slides, please. There will be three of us that will give a brief overview of the current situation globally, as well as focusing on Africa. Next slide, please. We first put this into context. So what you'll see here are two maps. On the right-hand side are the numbers of countries that have reported mpox cases since the beginning of 2022. And on the left-hand side, you will see the countries that have reported just in the month of July alone. So while we had a public health emergency of international concern in 2022 and 2023, largely led by this clade 2 virus, that was brought under control with concerted community action and a number of different interventions. But the virus continues to spread. Next slide, please. What you will see, and you will hear more about this from my colleagues, is that the recent upsurge of mpox is what led the Director General to announce a public health emergency of international concern. What we have here is a focus on the DRC, but also neighboring countries, some of whom have never reported mpox cases before. You've heard from our three opening remarks that we are looking at in a challenging situation of surveillance. We don't have full visibility on the epidemiology and the spread of these viruses. The concern that we have is not only the increase in cases, but this new clade 1b, which is circulating in the DRC, but also in neighboring countries, most notably in Burundi. Next slide, please. So you've heard this from all of our speakers so far. What we are working towards is a global coordinated action with WHO, with all of you, with Africa CDC, with all of our partners. Not one of us does this alone. So you already know that the public health emergency of international concern was announced on the 14th. We've had the announcement from Africa CDC the day before. This is an evolving, it's a dynamic, and it's a concerning situation, and things are changing. We are doing our best with all of you to better understand what is unfolding so that the response can be precise, it can be tailored, and that the resources that we do have, we can use focused on the people who are most at risk. So a global strategic preparedness and response plan was presented to member states last Friday. We have a significant scale up in affected countries, and with thanks to all of you and to your workforce who are on the ground, who are addressing this. And for us, as always, partnerships are what is successful and what will be successful to stop this outbreak. Next slide, please, and this is my last. I wanted to highlight one aspect because as you've heard already, there's a lot of attention right now on vaccines. And of course, vaccines are important, but they are not the only control measure that we have. The global outbreak in 2022-2023 was brought under control by communities, by engaged communities who were informed, who were part of the response, who were part of the development of these interventions, and actually the use of these interventions. On the side of access to countermeasures, this covers many different components, not only guidelines and policy, but looking at research and development. And tomorrow and Friday, there will be a global R&D meeting that will largely be virtual. You are all invited, which is brought together by WHO, by CEPI, by Africa CDC, and others to make sure that we look at what are the latest priorities that we need across research and development. We are working on developing an ICG-type mechanism for the donations that are coming in, which you are hearing about, as well as their delivery. Again, vaccination needs to be used in a targeted way. We will not have enough vaccine to be able to be used for everyone. We have to focus on the at-risk groups. And there's a lot of work happening with regards to the supply chain management. Underscoring this is the regulatory approvals. And you've heard the Director General say that EUL is being used, and we hope to have answers on EUL in the next couple of weeks. So when we talk about countermeasures, we're not just talking about vaccines, we're talking about therapeutics, we're talking about diagnostics, as well as other health products. Dr. Fiona?
Dr. Fiona Bracker, Emergency Response Manager, who's in charge, you've just all heard from WHO Afro. Fiona, over to you.
The Director General, Dr. Tedros, Dr. Moweti, DG Dr. Kasea, Your Excellencies, I will just build on with a focus on the African region and what's happening with the outbreak as well as the response. So we are witnessing the increase in cases, as has been mentioned already, since early 2022. And in just the first 6 months of 2024, we have witnessed more than 4 times the number of cases compared to the same period in 2023. The surge is majorly driven by the outbreak in DRC, which accounts for 90% of the cases that have been confirmed. We'd also like to highlight that beyond the cases that are confirmed, there are thousands of suspect cases, and the testing capacities are limiting our understanding of the true burden of the disease. 24% of those suspect cases have been tested, and what's concerning is that over 60% of those that have been tested are actually positive for mpox. Next. This shows the geographic spread comparing 2022 and 2024. In 2022, we had 19 countries. 16 of these are in the WHO Afro region. And as of 2024, we have 13 countries in the WHO Afro region that have recorded an mpox case. Although the epi situation is not fully understood, What we do know is that we are seeing two distinct outbreaks in the DRC. The clade 1A is affecting majorly children in the routinely endemic mpox provinces and regions. And then the second outbreak is related to the clade 1B, which is the new strain that has emerged. And it's spreading through majorly to adults in the eastern provinces of South Kivu and North Kivu. The data indicates that it is spread majorly through sexual contact, especially among networks of commercial sex workers and their clients. The surge in DRC is of a further concern because we have seen it spread geographically to Burundi, to Rwanda, to Uganda and Kenya in the last couple of months. These outbreaks are linked to the clade 1B outbreak in the DRC. In addition, we have reports of cases in Sweden and Thailand, again linked to the clade 1B strain. This strain also is particularly concerning because of the severity, especially in immunocompromised individuals as well as children and pregnant women. Just to highlight, next slide, the key takeaways in terms of the epi situation. We have a dynamic situation that is evolving with additional countries that have reported their first cases in 2024. The total number of countries affected has risen to 16 for the WHO Afro region since this outbreak started in 2022. And we are seeing confirmation of the clade 1B strain beyond DRC to neighboring countries, and particularly also concerning is the growing outbreak in Burundi. The limited surveillance and testing capacities, diagnostic capacities, complicate the understanding of the true burden of the outbreaks and hindrance to the response to the outbreaks. Our next slide, our Director General has noted the standing recommendations that were issued in August of 2023 and have been extended for an additional year to August of 2025. These recommendations are for all state parties and they focus around next slide please. They focus around seven major areas, and they are in accordance with the international health regulations. Next slide. The Director General also highlighted the temporary recommendations that have been issued in relation to the public health emergency of international concern. These have been issued to state parties at risk. We'd just like to emphasize that they are complementary to the standing recommendations and that they are specific and targeted around 9 key thematic areas. These have been shared with member states and are also available on the web. We would like to, next slide, commend the great effort that has been underway by affected countries and countries at risk in trying to scale up the capacities as well as response interventions. We thank you for all the collaborative work that is going on, and we'd just like to highlight some of the scale-up interventions that are underway that we are working with you to support in this response. In the DRC and Burundi, we are surging up capacities. We have over 400 repurposed staff and consultants that will be working with the two countries to scale up the response. And we are also working with the other affected at-risk countries to finalize their plans and ensure we have the necessary surge capacities to respond. In the DRC, we have 9 subnational offices that are being strengthened to facilitate coordination. Thanks to the investments in COVID-19 response, we have pre-positioned supplies that were available at the Nairobi hub with the support of USAID majorly, and these have been disbursed to 5 countries in the region, and work is underway to increase those supplies, especially around the testing, the supplies needed for testing, a push order of about 2,500 mpox tests per country is in the pipeline for 8 countries and should be arriving soon. We have conducted on-site visits and training in 45 countries to facilitate expansion of genomic surveillance. We are pleased that with the investments in COVID, all the countries in the region have PCR testing capacities, and we are building on those capacities to further increase and improve our diagnostic and sequencing capacities. As we speak, there is a training that is going on at IP Dakar this week in collaboration with WHO and WHO to provide, strengthen those capacities further among the lab personnel. And we are working to establish a network of regional reference laboratories across Africa. A lot of work around clinical care management, the guidelines, as our DG had mentioned, have been provided, and capacity building has also been provided to train health workers in the clinical care of mpox cases. My last slide is highlighting also in terms of financing. We have released $1.5 million from the contingency fund for emergencies, and an additional $2 million is currently under review, which we hope will be approved. And all this funding is majorly supporting the response initiatives at the country level to scale up the response. A lot of work around surveillance intensification. If we do not monitor, if we do not report, we are not able to respond promptly. So we want to thank you for the integration of mpox surveillance within the IDSR framework that is already existent in the countries, that is helping us to be able to report and monitor the outbreaks. There is a lot also going on to prepare the countries for vaccination. Particularly DRC, South Africa, and we had also Nigeria yesterday has received some vaccines. So the planning around identifying high-risk groups, the work around vaccine regulatory processes that has to go hand in hand through the African Vaccine Regulatory Forum. We are working with 13 high-risk countries to support the authorization of these vaccines through the emergency use listing, should that come into effect soon. We also are working with the national immunization technical advisory groups to ensure that there is evidence-based information available to guide the decisions around vaccine introduction. Our regional director talked about the infodemics, the information that is out there, the misinformation, and a lot is being done, thanks to your support, in ensuring communities are sensitized, the media is sensitized. We've worked together around orientation of journalists and also community-level sensitization to provide the necessary information, but still a lot more needs to be done. For those that have not reported cases, we want to emphasize the need for readiness, ensuring that the capacities are in place. We have worked with countries to conduct readiness assessments through a self-assessment process. The tools have been distributed to countries, and so far we have received responses from 18 countries, and feedback has been provided. We want to highlight the overall readiness from the countries that have responded is around 50%, and this average is pulled down majorly around components related to vaccination, to supplies, and to coordination. So we need to continue to work to build those capacities and be ready in the countries to respond effectively. Honorable Ministers, I thank you for your attention.
Thank you, Fiona. And I'd like to now welcome Dr. Ngashi Ngongo, who's the Chief of Staff and mpox Incident Manager for Africa CDC. Dr. Ngongo, over to you.
Thank you very much, Madam Chair, Your Excellencies, members of the delegations, Director General Dr. Tedros, Director General Dr. Jean Kaseya, RD, distinguished guests, I'm going to present the Continental Preparedness and Response Plan for mpox outbreak in Africa, which is a 6-month plan developed through a very inclusive process that involved all the 13 member states that are affected now by mpox, together with the key partners and the 16 members of the emergency consultative group that were really invited also and have provided very constructive feedback into this process. I have to say that this is the first time that WHO, Africa CDC are working in this very well-coordinated manner to produce one single continental plan that includes the activities of the member states together with the technical assistance of the partners in a way that can facilitate transparency, synergy, efficiency, and accountability. The overall goal of this plan, next slide, is naturally to stop the transmission of the mpox virus in affected member states, but also support preparedness and prevent the spread to the non-affected member state through a continentally coordinated approach. Now, in thinking about the plan, next slide, we identified 5 guiding principles, 9 key response pillars, and 8 implementation strategies. I think the guiding principles include a unified approach that explains why we are bringing all partners in a single plan to work together, a country-driven process that builds on the priorities that you have already identified yourself as a member state, an evidence-based response that really builds on the science, an equity focus that also targets the most deprived, and finally, a sustainable response that focuses on long-term solutions that can stay beyond the intervention of this plan. In terms of the response pillars, we have 9 of them that include the coordination and leadership at all levels, at continental level, at national level, and sub-national level. The risk communication and community engagement, which remains a major pillar in the absence of the medical countermeasures. The surveillance, the laboratory capacity strengthening for early detection, infection prevention and control, both at community and at health facility levels. The medical countermeasures, starting with the vaccines that we are talking about, but also diagnostics and therapeutics. The case management, that's very, very much integrated. That includes both the medical care, but also the nutritional care and psychosocial support. The continuity of essential services to ensure that there is no disruption in the context of the emergency response. And finally, the research and innovation, because there's a lot to learn, many questions that are not yet answered when it comes to the mpox outbreak. Now, in terms of the implementation strategies, 8 of them. The first is to establish one functional coordination structure with one team, one plan, one budget, one M&E framework at continental level, but also at national and sub-national level. And the second strategy is to engage communities, especially the most vulnerable populations, to practice the key public health recommendations and access the needed services when they need them. The third strategy is to enhance surveillance with quality data, active case funding, and contact tracing. And the fourth is to strengthen, the most important, to decentralize laboratory capacity for testing to the sub-national level, given the difficulties of the sample transportation in most of our countries. The fifth is to improve infection prevention and control measures at both community and health facility level, including building the skills that are needed, providing the equipment and supplies, and also establishing the wash facilities. And the seventh is to support an integrated case management approach that is really holistic in nature, with isolation facilities for those that are critically sick and need isolation. And the 8th is the ring vaccination, targeting the most at risk health workers that we talk about, and also the contact of confirmed cases, targeting also the most vulnerable, those that are immunocompromised, HIV, malnourished, and finally, the key populations because of unsafe sexual practices. And finally, is the coordination of the research to improve access to medical countermeasures and better understand the epidemiology of mpox. Next slide. Now, what is most important this time is this new continental approach to emergency preparedness and response in Africa. That will make the difference. I think the content of that is 4 main things. One is this concept of one team, starting at continental level, but this time that is going to be co-led by WHO and Africa CDC. And then secondly, is to recognize the comparative advantage of different partners that always support our emergency responses in the wake of the different work streams so that them also can lead in areas that they are the best in town in terms of the expertise and the resources. Now, the second point is the one plan concept, which is really this time the product of co-creation. I think all of you did receive the draft plan and we are receiving very constructive input. And this is critical really to harmonize and align our effort to ensure that there is a complementarity instead of wasting the limited resources. The fifth is the one budget, which is really consolidated, putting together the budget of the member state and also the budget of the different partners that are intervening. And finally is one MNE framework that we've harmonized public health measures that are used by all stakeholders to monitor the progress that we are making in addressing the mpox outbreak. Now, what does that mean in practice? We are just giving an example here. Let's move on to the next slide of how we see the functioning of that single continental incident management team. At the coordination level, we have Africa CDC and WHO co-leading. At the operations level, it's also Africa CDC and WHO co-leading. But in the different pillars of the response, we try to identify the organization that has got the comparative advantage over the others. For example, on communication, risk communication and community engagement, where UNICEF will lead in that area. But all of us, WHO, Africa CDC, USAID, CSO, IFRC, will be also support partners in that space. On surveillance, we know that WHO has a comparative advantage on lead that. On laboratory, Africa CDC will lead with the support of WHO and other partners. On vaccines, UNICEF will lead with Africa CDC, WHO, Gavi, and others. On case management, Médecins Sans Frontières will be the lead with the support from WHO, Africa CDC, and other partners. And on IPC, WHO will lead us. The same when it comes to the logistics, I think the leadership will be given to the World Food Programme, but with support from UNICEF and other partners. On planning, Africa CDC, and then on research, it will be CEPI with the support of Africa CDC, WHO, the US CDC. Just to give you a clear demonstration of this working together into what it translates, when it comes to the incident management team. Next. And we also have pulled together the numbers to try and understand the ambition of the budget that we are looking for. I think we've come to the first estimate of 245 million that are needed, of which 80% of that for the member state and 20% for the partners. But we've also looked at the money that's available. On the side of the member state, we just had the government of the Democratic Republic of Congo that decided to put $10 million to support the outbreak, and also at the AU level, Africa CDC received an approval of 10.4 million. That's about 20 million that are already available, and then we continue with the resource mobilization, and we'll be updating these figures. Now, the current gap where we stand today is about 224 million we are looking for. But I would like just to also put a caveat here that we are receiving comment and input from different member states and partners until last night, which means that by Friday, when we launch this report, there might be some slight adjustment, including on the budget that I've just presented now. And finally, just wanted to give also an update on the state of the response on the Africa CDC side, that we have set up this one Continental Incident Management Support Team whose headquarters is in the DRC because of the simple fact that that's the epicenter of the outbreak. It's a 24-member team that's already there, and we are expecting 6 members from one organization this week, and many other organizations are also sending their representative to be based in Kinshasa with the team. On the funding side, as I said, 20 million already secured, and the mobilization continues. On the surveillance and laboratory testing capacity strengthening in the member state, we just completed the training of 7 affected member states in sample collection, diagnosis, and sequencing in Kinshasa. We are deploying 72 epidemiologists to the affected member state, and we are also supporting the decentralization of laboratory capacity with over 20,000 cartridges that are being distributed in the member state. On the mobilization of vaccines, we signed an agreement with HERA and Bavarian Nordic for an initial donation of 215,000, but we heard the DG when he was addressing updated that number to say that we have now France, we have Germany, we have Spain, we have the US that are all pledged to donate mpox vaccines now, bringing this number to 1 million doses that are donated at present, and that continues. And in addition, I think the discussion of Bavarian Nordic indicate that they are very much willing to boost the production this year to deliver at least 3 million doses and another 7 million next year to reach the target of 10 million doses delivered by the end of 2025. And finally, on the coordination of the research, mpox research, tomorrow in Kinshasa, there's a Continental R&D conference that is being organized to address the knowledge gaps in medical countermeasures. Your Excellencies, distinguished guests, thank you for your attention.
Thank you very much. You've heard from the experts about how we're driving collective mpox action. The technical updates were thorough. You've seen the work that is ongoing at country level. We've heard that there is a broad spectrum of work being done, including training in diagnostics and screening, working with regional institutions like Institut Pasteur. You've heard about the combined action plan. And now it is time to hear from their excellencies, ministers of health. I said earlier that Africa must be master, mistress of her own destiny. And so, as we hear from ministers of health, your excellencies, we as a continent must continue to call on our leaders to invest in our own health systems. These cannot be left wanting. As those of you who have heard me say this before, I continue to call on you all to meet the obligations, please, set out in the Abuja Declaration of over 22 years ago. I would now like to, as I've noted the importance of national sovereignty, also note the member states are at the very heart. It is you that WHO serves. It is you that Africa CDC serves. And therefore, we want to invite, keen to hear from ministers of state from 3 mpox affected countries particularly. And we will hear first from His Excellency, the Minister of Health of the Democratic Republic of Congo, who will speak with slides, I'm told. Your Excellency, the floor is yours.
Merci beaucoup, pour la parole, Monsieur le DG de l'OMS, Madame la directrice régionale, Monsieur le DG de l'Africa CDC, ainsi que tous les intervenants. Merci pour vos premières interventions qui ont balisé, qui ont éclairé sur toute la situation d'Mpox. Donc je ne vais pas revenir nécessairement sur tous les plans parce qu'en fait, on a adapté les mêmes plans au niveau de notre pays, la RDC. Je voudrais d'abord insister sur le fait que le premier cas de mpox a été découvert en RDC chez un petit enfant de 9 mois, mais j'en parle parce que c'est en 1970, j'en parle parce que ce cas n'a entraîné aucune autre contamination autour de lui, tout simplement parce que tout le monde était déjà à cette époque-là vacciné déjà contre la variole. Ce qui montre l'importance de la vaccination et ce qui montre pourquoi est-ce que la RDC Ouais, on peut passer les slides si vous voulez. Le slide suivant, je vais aller vite. Alors, cette épidémie-là de 2022, vous voyez bien qu'elle a été résolue assez rapidement avec des mesures qui ont été prises. Et ces mesures-là, nous pensons qu'il faut qu'elles reprennent chez nous pour que nous puissions aussi maîtriser. Slide suivante. Alors donc je vous ai dit, c'était en 1970 qu'on a découvert ce premier cas, mais ce premier cas n'a entraîné la contamination d'aucune autre personne autour d'elle, parce que toutes les personnes étaient à cette époque-là vaccinées contre la variole. Donc c'est très important pour nous les vaccins. Alors, si on regarde le slide qui suit, pour montrer un peu l'évolution de 2022 à 2024 en RDC, je peux le résumer avec le slide qui suit encore. Si vous regardez le carré qui est en bas à droite, vous allez voir qu'en 2022, on était à 5697 cas et en 2023, 14 626 pour toute l'année. Et aujourd'hui, quand je parle, nous sommes déjà à 17 801 cas. Donc ça montre bien la progression effectivement rapide de la maladie. Et le nombre de décès, par contre, si vous remarquez bien, le taux de létalité est en train de baisser, qui est passé de 4,1 à 4,5, puis maintenant, actuellement, on est à 3,2. Alors, je voudrais ici insister sur la province du Sud Kivu. Si vous regardez le tableau qui est à gauche, en haut, où on parle maintenant de l'épicentre qui est parti au Kivu, avec 606 cas, donc ça c'était seulement pour la semaine 33. Mais regardez, il y a eu 5 décès. Ça montre bien que cette information nous donne 2 éléments. Le premier, c'est que la recherche active des cas, la recherche avec la surveillance, nous permet de détecter beaucoup de cas et de les détecter précocement. Et quand on les détecte précocement, effectivement, le taux de décès est très faible. Vous voyez qu'il y a 5 décès sur 606 cas détectés. Et donc, je voulais ici insister sur cette importance de la surveillance, de la détection rapide et surtout aussi de la prise en charge, parce que vous avez vu que dans la planification, la prise en charge est importante. Slide suivante. Ce qu'on remarque quand même en RDC, c'est cette distribution de l'épidémie autour de la cuvette de la forêt. On voit quand même que l'épidémie, les cas sont beaucoup observés au niveau donc, de la forêt équatoriale, où l'écosystème est très favorable avec la circulation des écureuils, des singes, et effectivement, on voit ces déplacements de virus de l'ouest, c'est-à-dire la zone rouge à l'ouest, vers la zone rouge à l'est avec le clade 2, 1B, comme on l'a dit tout à l'heure. Mais ici, on voudrait que les chercheurs essaient de nous trouver, les épidémiologistes essaient de comprendre pourquoi ces distributions un peu en ligne au milieu du pays, suivant la cuvette équatoriale. Slide suivante. Alors, quand on regarde maintenant l'arbre phylogénétique de clade 1A et 1B, on voit que le 1B circule surtout au sud Kivu et au nord Kivu, mais on a quand même déjà détecté aussi un cas de 1B à Kinshasa, et le 1A qui circule dans le reste du pays, donc dans les 22 provinces. Nous avons une capacité de détection, de diagnostic avec 2 laboratoires, un à Kinshasa et un à Goma, qui sont des laboratoires de l'INRB, qui permettent en fait que nous puissions faire le diagnostic. Mais nous sommes en train, et là l'Africa CDC est en train de nous aider avec l'achat des cartouches, nous sommes donc en train, avec 6 laboratoires fonctionnels, de permettre au Gene Expert, qui est beaucoup plus répandu, de permettre de faciliter le diagnostic le plus proche possible des cas qui sont identifiés. Slide suivant. En termes de plan, comme j'ai dit que je ne vais pas trop insister parce que c'est quasiment le même plan qui a été présenté par Africa CDC, mais que nous avons aussi adapté chez nous. Slide suivant. Slide suivant, s'il vous plaît. Alors, nous aussi, on a une coordination unique et nous avons demandé qu'il y ait un seul plan, un seul budget et une seule coordination. Et nous avons bien entendu lancé effectivement la communication des risques et l'engagement communautaire. Par rapport à l'engagement communautaire en RDC, ce qui est particulier, c'est que nous n'avions pas de relais communautaires qui étaient opérationnels de manière systématique, ils étaient occasionnels. Nous avons donc décidé d'opérationnaliser les relais communautaires pour qu'ils soient des permanents et qui fassent ce travail de manière à ce que la surveillance épidémiologique soit assurée au niveau communautaire. Nous avons aussi décidé que la prise en charge de malades, aussi bien au niveau médical, au niveau nutritionnel et psychologique, soit complètement holistique. Mais cette prise en charge chez nous, elle est gratuite, étant donné effectivement qu'on veut que les malades viennent se présenter, on ne veut pas que les malades fuient. Et donc, la prise en charge, elle est gratuite. Bien sûr, nous faisons la prévention du contrôle des infections, la logistique, le laboratoire, j'en ai parlé, et nous sommes en train d'attendre les vaccins. Alors, par rapport aux vaccins, nous avons effectivement le soutien de l'Union européenne, grâce à Africa CDC, mais grâce aussi à d'autres partenaires, avec une annonce de 215 000 doses de vaccins. Je serais bien content de savoir comment est-ce que mon frère du Nigeria a fait déjà pour recevoir les 100 000, mais nous, on attend encore. Et bien entendu, il y a aussi le Japon, je n'ai pas trop entendu ici, nous sommes en train de travailler avec le Japon pour pouvoir obtenir aussi des vaccins qui pourraient être utilisés chez l'enfant. Alors, slide suivant, s'il vous plaît. Donc, nous avons effectivement des mesures de contrôle qui ont été adoptées et leur impact sur le contrôle de la transmission du mpox commence à se faire remarquer. Je vous ai parlé du Sud Kivu où on détecte beaucoup et où effectivement la détection précoce entraîne une conséquence positive, c'est-à-dire une diminution de la mortalité grâce à la prise en charge. Et nous sommes en train aussi surtout de regarder les personnes, les populations clés et ainsi que les programmes connexes comme le programme de lutte contre le VIH que nous intégrons aussi. Slide suivant. Alors pour la stratégie de vaccination, nous avons décidé de vacciner d'abord le personnel de santé de première ligne dans les zones de santé touchées, les populations clés qui sont les professionnels de sexe, les hommes ayant des rapports sexuels avec d'autres hommes, ainsi que les transgenres. Mais aussi, nous avons décidé que dans les zones affectées, les enfants de 1 à 17 ans soient vaccinés, ainsi que les vétérinaires, les chasseurs, les éco-gardes. et les personnes en contact avec les cas confirmés. Nous avons pour objectif de ce vaccin, slide suivante, 2 objectifs: interrompre la chaîne de transmission et réduire la létalité. Et donc, je vous ai dit les différents vaccins que nous sommes en train de regarder, le LC16M8 avec les Japonais et le MVA-BN pour la réponse vaccinale. Voilà à peu près ce que nous sommes en train de faire en RDC. Je vous remercie.
Merci beaucoup, Monsieur le Ministre. Very good to hear the incredible work being done. I would like to congratulate you on the work being done at the very epicenter of this outbreak in Africa at the moment. I'm going to move very quickly on, as we're running out of time, to the Honorable Minister, His Excellency, Minister of Health for Burundi. You have slides, I believe. And if I may remind all presenters that you have 5 minutes. Thank you very much. Can we have the slides up, please? The floor is yours. Oh, he wants to come up. Okay.
Merci, Monsieur le Président, pour la parole accordée. Monsieur le Président, Excellences les ministres ici présents, Monsieur le Directeur général de l'OMS, Madame la Directrice régionale de l'OMS pour l'Afrique, chers invités, tout protocole observé, bonjour. Je suis honoré de représenter Madame le Ministre de la République du Burundi pour vous brosser brièvement sur la situation de la maladie mpox au Burundi. Le Burundi a déclaré les premiers cas de la maladie mpox en date du 25 juillet 2024 et jusqu'à présent. Jusqu'au 25 août, le cumul des cas suspects depuis l'apparition de l'épidémie s'élève à 820, parmi lesquels 702 ont été investigués et validés, 10 sont en attente d'investigation. Et le cumul des cas confirmés de la maladie mpox est de 231 cas dans un mois. Au total, 29 districts sanitaires sur les 49 que compte le pays sont déjà touchés par la maladie. Et signalons que le taux de positivité est de 37,7%, car sur un total de 622 tests réalisés depuis le 25 juillet, 250 sont revenus positifs. Malgré cette situation si alarmante, la bonne nouvelle est que le Burundi n'a encore enregistré aucun décès dû à la maladie mpox et nous avons déjà 38 cas déchargés malgré une prise en charge délicate. La technique, s'il vous plaît. La slide suivante. Voyez ce que je disais. Retournez en arrière, s'il vous plaît. En arrière. Encore, s'il vous plaît. Voilà ce que je disais. Et résumé sur ces deux schémas, vous voyez que presque tout le Burundi est concerné par la maladie. Et signalons que les tranches d'âge les plus touchées sont les enfants de moins de 5 ans. Et je peux signaler que ce sont les enfants de moins de 5 ans qui sont les plus touchés, avec une proportion de 49%. Le mode de transmission n'est pas encore connu au Burundi. Et les examens faits au laboratoire national de référence de l'Institut national de santé publique ont permis d'isoler le virus de clade MB. Et nous n'avons pas encore mené aucune étude pour identifier les principaux modes de transmission de la maladie mpox. Et dans les séances de sensibilisation de la population, nous nous référons au mode de transmission décrit par la littérature et suivant les recommandations de l'OMS. Quelles sont les actions de santé publique déjà menées ou en cours d'être réalisées? Nous avons déjà élaboré et validé un plan de riposte de l'épidémie mpox qui va coûter 14 millions de dollars américains sur une période de 6 mois, qui a pris compte de l'approche One Health, parce que quand nous avons élaboré et validé ce plan, tous les parties prenantes étaient là, l'OMS, tous les systèmes des agences des Nations Unies et les autres ministères comme le ministère en charge de l'environnement, de l'agriculture, de l'élevage. Il y a eu un engagement prompt du gouvernement pour financer ce plan. Et je peux signaler que même au lendemain de la publication de son plan, on a pu débloquer environ 1 million de dollars pour pouvoir accélérer avec la prise en charge des malades. Nous sommes en train de capaciter le laboratoire national de référence pour qu'il puisse identifier les différents clades de mpox. Nous travaillons d'arrache-pied pour faire le briefing, pour capaciter les médecins directeurs des provinces sanitaires et des médecins chefs de district sur la gestion de mpox. Signalons que la prise en charge est holistique et gratuite pour tous les patients. Nous tenons compte du protocole national qui a été élaboré. Mais l'alimentation est prise en charge gratuitement avec l'appui des partenaires comme l'UNICEF, le PAM et le Médecins sans frontières. Nous sommes en train de capaciter les districts sanitaires et sécurité sanitaire pour l'investigation des alertes, l'acquisition des intrants pour le dépistage mpox, la notification, le diagnostic et la prise en charge des cas. Le déploiement des équipes de surveillance est actif pour les investigations, le traçage et le suivi des contacts. La prévention se limite actuellement à diffuser des messages de sensibilisation. La vaccination n'est pas encore introduite. Nous procédons actuellement à désinfecter des ménages touchés dans les quartiers les plus vulnérables, parce que là, nous avons montré une slide où, par exemple, à mairie de Bujumbura, la capitale économique, il y a une partie de la ville qui est très touchée, et ce serait lié à des conditions d'hygiène qui sont précaires dans ce quartier. Quels sont les défis majeurs? Les contraintes sont essentiellement liées au financement de notre plan déjà élaboré pour pouvoir mener une réponse coordonnée en touchant tous les piliers, surtout la surveillance épidémiologique, la prévention, le diagnostic, parce qu'actuellement, seul le laboratoire national de référence réalise des tests de diagnostic parce qu'il est doté des consommables adéquats et des équipements comme les cartouches. Et nous avons besoin un besoin réel de pouvoir décentraliser le diagnostic dans les hôpitaux de l'intérieur du pays en leur renforçant en consommables comme les cartouches, d'autant plus que la majorité de ces structures sont dotées des appareils jeunes experts. En conclusion, le Burundi déploie assez d'énormes efforts dans la riposte contre la variole simienne avec un focus sur la prévention et la surveillance et les moyens de diagnostic. Cela se manifeste par un engagement politique qui s'est affiché au lendemain de la déclaration de l'épidémie. Nous tenons ici à saluer déjà la promptitude et la proactivité de l'OMS à travers son bureau pays et l'Africa CDC qui affiche l'engagement sans égal aux côtés du ministère de la Santé publique du Burundi, mais aussi la mobilisation et la coordination d'autres partenaires et d'autres agences des systèmes des Nations Unies basées à Bujumbura, dont je tiens encore une fois de plus d'exprimer les remerciements. Toutefois, le Burundi a encore besoin d'un appui et accompagnement supplémentaire, surtout en termes de renforcement de la préparation, la surveillance et les moyens de diagnostic. Et le financement du plan de la riposte déjà élaboré est encore très insuffisant. Nous appelons à une collaboration et partenariat continental et régional en particulier, surtout avec les pays frères avec qui nous partageons les frontières pour une surveillance sans faille, sans oublier le partage des informations. Je vous remercie, Monsieur le Président.
Merci beaucoup. As we're running out of time, I'm going to go very quickly now to the Honourable Minister, His Excellency Dr. Aaron Motsoaledi from South Africa. I welcome you now to make your statement. Please do remember you have 5 minutes. You are, all of you, this session is standing in between you and lunch. So if we can please make sure we have enough time for questions and answers. Your Excellency, it's yours.
Thank you, ma'am. I also have slides I can present from here if the Secretariat can move the slides. Yes. Thank you very much. Can you go to the next one? No. Yes. Yeah. mpox started in South Africa in 2022 with 5 unlinked cases of male having sex with males. In 2023, there were no cases. In 2024, there are 24 lab-confirmed cases of mpox. In 3 of our 9 provinces, they are associated with clade 2B. Next, that is just a graph showing the extent in South Africa. Next, the summary here. Next slide, yes. Our summary is that out of the 24 laboratory confirmed cases, 12 cases, just 50% are in Gauteng province. That's where the capital city is. 11% are in the province of KwaZulu-Natal, and one case, 4% in Western Cape. That's where Parliament is. All cases are male, age range between 17 and 43 years old, median age 33. The earliest recorded date of onset of symptoms of the 24 cases is 15 February 2024, and presently all 22 cases of these 24 have all completed contact tracing. That is 92% of the cases. Next, for where details are known, 16 cases, that constitutes 67%, had underlying medical conditions. They were all HIV positive, either with unmanaged or recently diagnosed disease. 11 cases, or 46%, self-identified as men having sex with men, and 5 of them, constitute 23%, had access to tecovirimat through SAPRA. SAPRA is the South African Health Product Regulatory Authority, the medicine regulator in our country. And Section 21 means drugs that have not been regulated or registered but are given on compassionate basis through Section 21 of the SAPRA Act. As we said, 3 mpox-related cases have died. That is a 13% case fatality rate. Just to give you a summary again there, 19 people have recovered, 3 have died, 2 are still active, 5, as I said, received tecovirimat, and the total is 24. On the issue of leadership, we just showing that mpox is now a notifiable medical condition in South Africa. Community health, healthcare workers have to report if they get a suspected case. They must report within 24 hours. Can you move? Yes, next slide, next slide. Next slide. Yes. Epidemiological and outbreak response investigation were initiated. 700 tests have been performed in both public and private because we think we have got capacity to do so. Next slide. Maybe I can leave that one. Case management, next. Cases have been isolated in hospitals or at home with effective, infection prevention protocols being done. Can we move to the next slide? On communication, risk communication and community engagement. The strategy has been developed to reach high-risk populations with mpox messages, working with relevant. Can you move? No, I'm not yet there. Unfortunately. Okay, maybe just to mention that we're working with stakeholders. The next slide, which is there, just summarizes the laboratories. Pathcare, Lancet, and Empath are all private laboratories. The last one there, which is public NICD, is our National Institute of Communicable Diseases. They've done most of the tests at 458 tests done by them. Next. Yes, I'm there now, showing that there is not much difference between male and females in as far as the tests were performed. Red pink there is female, blue is male. Next. Let me skip that one. Can you go to the next one? Yes. Our request to the international partners is tecovirimat access through donation from WHO, ongoing support with access from WHO should the need increase. At the moment, South Africa requires 40,000 vaccine doses for high-risk group for pre and post exposure. Next, additional technical assistance is requested from WHO and Africa CDC to support the integration of mpox response into HIV, AIDS, and STI, sexually transmitted infection services, into expanded program on immunization. Thank you very much.
Thank you very much, Minister, for your quick presentation. Very different epidemiological picture emerging there. It's interesting to see the differences between the outbreak in DRC, Burundi, and then in South Africa, sort of a lot more targeted, although we do know that unless we test, we won't find. Really, the next thing for us to do is to find out how we're going to reach the finish line. The co-chair of the IMB, the Intergovernmental Negotiating Body, Precious Matsoso, here, has been working incredibly hard together with her colleagues in the Bureau, colleagues at WHO, Dr. Tedros, many others, on the IMB process. But what this mpox FEC highlights is a criticality of needing to finalize an agreement that all governments everywhere will implement and that everyone everywhere will benefit from. So what do we need to help you, the member states, get the IMB across the line? The IMB co-chair, Precious Matsoso, Professor Precious Matsoso, will deliver an update. I hand over to my sister, Precious.
Honorable ministers,
Your Excellencies, Regional Director Dr. Moeti, Dr. Tedros, Dr. Kasea, thank you so much for giving me this opportunity to update you. I won't be long because you have to go for lunch. But I also wanted to take this opportunity to thank you, ministers, because the Africa region is probably the only region where the ministers have been engaged with this issue, where ministers have boldly said, we'd like to see this instrument because we think it's important. It's important because it's going to prioritize equity. Inequitable access was at the heart of the COVID pandemic. As we speak today, we are now tackling mpox. Next time, when we meet again, it will be because we have an instrument that has helped us prevent any pandemic from happening. It will be an instrument that would have helped us prepare, but also an instrument that will help us prepare better. You took this decision in 2021 based on a special session of the World Health Assembly. It was the second time that the World Health Assembly had a special session. If we meet in December and we conclude this, it will be the third time that the World Health Assembly will have a special session. And the extended time you've given us to reach the finish line is possible, it's doable, and we can do it. But what is important, and I'd like to reinforce this, is that we do not just want an instrument for the sake of an instrument. We want an instrument that will be based on equity, that will be future-proof, that will also be science-based, and it must be bold enough to help us respond better, and it must ensure that there's synergy between whatever we're going to create and the international health regulations. Because remember, the international health regulations is an already existing instrument. It predates most of us. It was adopted from 1948, immediately after the World Health Assembly, and the World Health Organization was established, and it was adopted at the Fourth World Health Assembly. So this is an old instrument that has seen repeated and iterative processes where it was amended. But it's quite clear that it didn't get us ready when COVID hit. And it is for that reason that we need both the IHR and we need the pandemic agreement. So it is for that reason, if you go back to the IHR, you'll realize that we have a commitment through IHR because the member states amended this very instrument at the World Health Assembly, the 77th World Health Assembly. But it's clear also that those amendments were not sufficient. It is for that reason that we need the pandemic agreement. So we have made considerable progress. We have 34 articles, and of these 34 articles, 50% are agreed, they are green. The remaining 50% are partially agreed. And that partial agreement I'm presenting to you because you have, ministers, already solved the problem. You have solved the problem because when you adopted the amendments to the international health regulations, you also presented some technical terms that can be relied upon. And I just want to give you a sense of the progress, how you've helped us propel this work. Firstly, if we look at some of the definition of terms, some have already been adopted and agreed upon in the IHR. And of these, for instance, pandemic emergency,
we have 10 articles where the word pandemic emergency is referred to. So we don't have to repeat that, we don't have to reinvent the wheel. So during these negotiations, if we agree that the word pandemic emergency can be adopted, it can just be well, it's not copy and paste. Of course, we have to do a bit of technical work. But in essence, 10 articles can already be resolved. So it is for that reason that reaching the finishing line is possible. We also have a definition, for instance, of relevant health products. That is a broad definition. It allows us to accommodate all technical tools that are needed for pandemic preparedness and response. If we adopt that term that is already agreed to by the health ministers when they adopted the amendments, would have resolved one of the problems in a couple of articles. And it is for that reason, ministers, that I want to assure you that of these terms, I just cited a few, but there are a few others. For instance, the mobilization of financial resources, coordinating financial mechanisms. I heard the Minister of Rwanda earlier talking about the pandemic fund. The language that we have currently in the pandemic agreement under Article 20 is whether we need to rely on existing financial mechanisms or whether we need new or whether we need both. And in that respect, if you look at that article, you'll realize that that's the only outstanding issue. If we resolve that, we would have adopted one of the key pillars of that instrument, because without finance, we'll not be able to move this agenda, and this instrument will not be implementable. I would like to assure you that of these 5 key strategic issues that are outstanding, most of you ministers have referred to them. And I think it is important that you guide the negotiators, that when they go, we can resolve these. The first one is on prevention and One Health. This particular issue is almost resolved. We're left with one issue: whether do we need an instrument in a form of a protocol or do we need an annexure? If we can agree on that, it means Articles 4 and 5 are agreed. Technology transfer, this is at the heart of what we'd like to see happen to achieve equity. And we had in most deliberations, interventions that were made earlier, that tech transfer is important. We'd like to see progressive language agreed to, so that this instrument is not just a piece of paper, but it is actionable and is also implementable. Pathogen access and benefit sharing. This is probably one of the key articles that the Africa region has been fighting for. And it has different levels of detail, and it's probably one of the key outstanding articles that we'd like to finalize. There are countries that are subjected to sanctions and unilateral cohesive measures, and they've asked that we find language that will ensure that we do not have barriers. And this is one particular area that we're trying to work on to find language. So these are the key areas, honorable ministers. Now, to resolve these speedily, we are meeting next week. We are bringing experts to look at the evidence and how best we can conclude this, so that when we have 2 sessions that we've planned for September and November, we can plan for all of you ministers to meet in December at the special session and adopt this instrument. And I look forward to that support, and thank you very much.
Thank you very much, Precious Matsoso, for that very succinct and very clear explanation of where we are, and really, most importantly, where we need to be and what is left to be done. We're a lot further along than we were. We're not quite there, But you've just heard that with a little bit of a push, we can be there. I cannot stress how much this mpox emergency has shown us. We're hearing that clade 2B took over 5 years to evolve for human transmission. Clade 1B has managed this in less than 1 year. 1 year. Clade 2B took 5 years. This one has taken less than 1 year. Mpox alone is evolving at a rapid pace. There is no time to lose. We must all act now. I now have a question and answer session, and we have a few member states whose sort of plates are up, and so I'm going to call them as they've been. I'm acting now on instruction, and I'm being instructed by those in the Secretariat what to do. And so I'm going to go first to Uganda.
Thank you very much, my dear sister. And I'm going to be very brief. I have questions, but I also have issues to raise. First, allow me to thank everybody up there who has given an input on this mpox issue, and also my colleague ministers who have submitted the situations in their country. It is common knowledge, and everybody knows that Uganda shares a border with DRC, the entire western border of Uganda. But I want to appreciate that since 1970 to 2024, there was no case that crossed over to Uganda. That shows you that one, work was being done, but also that whatever variant was there was not very virulent. To the Director General, this is yet another outbreak that may blow out of proportion if we don't put keen interest, high level of research, and mechanisms for control. It has happened already in the face of difficulty in accessing diagnostics. Vaccines are still far from us. Therapeutics are not there. Countries still lack human resource capacities, and as you have heard from the various presenters, financial support. Looks like the picture of COVID. And yet, here we are with it. To date, Uganda has, we've reported 6 cases. We have tested 200 samples, including samples using our mobile laboratories, because we have various mobile laboratories that we can deploy at the point of care. But you can see it is a very low test positivity rate, and I will come to that later on. We have a preparedness and response plan. We have activated all that we have to activate, briefed our partners, set up isolation facilities, deployed our mobile labs. But here, again, there are things that I must bring to your attention. We have requested for vaccines, and we are waiting for the EUL. And again, it is a wait. The first thing I would like to bring to your attention is that there is need to reach out to countries to stop the aspect of blame games. This case came from here, this case came from here. We are in this together. If you have a case, declare a case. Instead of, waiting for blame games, because there are countries that are already set to start issuing refusing travels, travels from African countries to their countries. And I already saw one from France saying people should not travel from Uganda to France. And Uganda only has 6 cases. Wait a minute. So what about countries that have thousands of cases and they are freely traveling? There is the issue of cross-border collaboration. We don't have unique borders. All of us in Africa are one people. We need to have serious cross-border collaboration so that we can address these issues without stopping movements of people and trade, because this must go on.
although a number of these cases are coming out of sex. DG, these are my questions to you. You heard from the DRC. You also heard from Burundi. DRC has a test positivity rate of 60%. Burundi, it is 37.7. Perhaps in Uganda, it is only 3%. Meaning, there may be false positive or the test kits have an issue. And we need to understand that in the context of the mutating virus, especially the clade 1b, we could be missing cases because the cases that are being tested actually have signs and symptoms. Why is the test positivity rate so low? We need to answer that question. Number two, the vaccines that we are set to use are repurposed vaccines, smallpox vaccines. In the face of a mutating virus, we need to handle this with caution because we can be dealing with an evolution of a superbug. Hence, we need to rethink and invest carefully before repurposing a vaccine that may not work. Again, I go back to why and how this monkeypox, which was detected in 1970, and now it is blowing out of proportion in 2024. What happened along the way? Why did we not continue to follow this bug, knowing very well that we had vaccinated for smallpox and eradicated it? But look, something came out of that, monkeypox. We need to revisit the area of DRC to understand what happened, why we did not detect the mutation on time, what is happening in there that we don't know. Otherwise, we may be sitting on a time bomb. I thank you, but look carefully into the issue of financial support so that countries can respond. Thank you.
Thank you, my sister Jane. I'm going to go to the technical team very quickly to see if they have any comments, because they may answer some of the other questions on the test positivity and why we're not detecting their gene deletions in clade 1b that make it very difficult to detect, and that's a scientific question for somebody to go to. But do I want to go to? Yeah, DG Africa CDC.
Thank you, my sister, Dr. Cheng. Let me be clear on that. We had meetings with EU authorities. We had meetings with the US authorities. We had meetings with French authorities. I was telling you that I had a meeting with the state minister. We are clear with them, there is no travel ban to be applied to Africa. What we got, they said yes. But I'm so surprised to see that Uganda is under travel ban policy. Please send it officially to us. We'll deal with them, because this is unacceptable.
DG?
I will start. So just very briefly, just thank you very much, Minister, for these very thoughtful comments and concerns raised in this room. Just to highlight the question around surveillance and reporting and testing. So we fully agree on the importance of surveillance and having accurate, validated diagnostic tests. So there's quite a bit of work that's happening at looking at not just the machines, but also looking at the test kits that are available. There's quite some work that's looking at distinguishing between clade 2, clade 1A, clade 1B, and we want to make sure that the right tests are getting to you. So that is a priority of all of ours, to ensure that of the diagnostic tests that are available, they're reaching you. Fully support your comments around if you have cases to report them. This is really critical so that we can look and do constantly risk assessments. These viruses do not respect borders, and so working together remains absolutely critical, as well as utilizing your own sequencing capacity that you work so hard to develop and expand during COVID-19, as RD has pointed out. looking at the viruses, looking at the mutations is something that constantly requires investment, and that's something we're committed to working with you on. And just to reiterate what Dr. Kasea has said, that we do not recommend travel restrictions, and we fully recognize that there are some negative consequences to you reporting. We saw that during COVID, and we will work very hard to ensure that that doesn't happen to the best of our ability.
DG.
Yeah, thank you. I will stress the travel ban as we issued a temporary recommendation. So from our side, we don't propose any travel restrictions. So as my brother said, we will reach out to those who are trespassing actually this. Then on EUL, my sister Janet, you said waiting for EUL. No, there is no waiting here, because I said it actually in my speech. The companies haven't provided the full information until last Friday. So it's very difficult to issue EUL without getting all the information from the companies and assessing the information. So all the information came last Friday. It was incomplete before then. And as I said in my speech, we will finalize the EUL in the next, within the 3 weeks. It could be even less. So, but even then, we said to Gavi and UNICEF to go ahead and proceed with the procurement. Because from the information we so far have, we don't see any safety problems. So that's the central one, by the way. So we advise them to proceed with procurement, and they can proceed, and I hope they have done. Because I had a meeting more than a week ago with the CEO of Gavi, and we discussed about this issue, and that's when we gave them the green light to proceed. So there is no waiting. There was an article, by the way, that was published, I think saying the same thing, but it's not true. I just would like to underline that. It's not true. Nobody is waiting for the EUL. Procurement is proceeding, and the vaccines, as soon as the procurement is completed, they will be delivered. And we're tracking that regularly. And then on, why, this emergence, especially in North Kivu, among others, by the way, security is the problem. And I think you know that. Ebola, you remember from 2018 to 2020, took like 2 years to stop it. And the security problem in North Kivu fuels the outbreaks. You also remember that within the 20 months of the response to the Ebola outbreak in North Kivu, I have been there myself 18 times. 14 times, within the 18 months actually, 14 times. And I have seen firsthand all the difficulties in North Kivu and all the fertile ground for outbreaks. So it's not just responding to outbreaks, but if you ask me, the best medicine is finding a political solution for the problem in North Kivu that can help us to address not only the health situation, but other issues as well. By the way, because I have traveled more than 14 times in 18 months, they gave me a Nandi name, and my name is Dr. Paluku. And I know that place, North Kivu, Beni, Butembo, Katwa, very well. And I think we need to consider also the issues, the other compounding issues, especially the lack of security in the area and how many armed groups actually operate in that area. So that has to be, I think, one of the major reasons to the question that you have asked. Yeah, thank you.
Yeah, quickly on two issues. The first one, infodemics is not just about communities. I start to see how I have also the role to protect Tedros as African. I start to see how they start to attack Africans and exposing them. First, this article from New York Times. When I saw it, the first thing I did, I reached out to Tedros. He gave me the information that he already provided authorization to Gavi and UNICEF to procure vaccine. I called the CEO of Gavi, who confirmed this information. And I hope that New York Times must give opportunity to answer and to say this information is not right. The second one, today, I even shared with Tedros the link from RFI. I think people who have access to RFI website, they will see there is a video of Tedros saying that it's the end of public health emergency of international concern, because they are creating confusion. And this article later corrected that to say this is a lie. I think for this kind of things, you will see Tedros, Kaseya, Moeti, and others, they will be attacked, but please be careful on that. The last one is about the the eastern part of DRC. Just today, we created a WhatsApp group with some ministers, Uganda, Rwanda, Burundi, DRC. They have to talk among them. But you saw me meeting the president of Angola last week, the president of DRC, talking for authorities of Rwanda, congratulating them for the ceasefire. As Dr. Tedros said, without peace, we will not move forward. I think Dr. Tedros and myself, we are going to DRC tomorrow. We'll have again opportunity to talk with leaders. I will be in Burundi, in Rwanda. In a few days, we'll continue to advocate for peace. Without peace, we'll not vaccinate people.
Thank you, Dr. Kaseya. I have now a question. The Benin, Republic of Benin, the floor is yours.
Merci. Monsieur le directeur général, Madame la directrice régionale, Monsieur le directeur général du CDC Africa, je voudrais avant tout saluer vraiment la synergie d'action qui existe entre le CDC Africa et l'OMS, notamment la région Afro, qui se matérialise aujourd'hui déjà face à cette menace que nous avons par rapport à la variole du singe. Le Bénin, à l'instar des autres pays, depuis la direction du DG et de l'OMS, a enclenché un certain nombre d'actions qui sont basées sur les 9 piliers qui ont été présentés. Nous avons, depuis 2022, nous avons eu 7 cas au Bénin, mais il faut faire très attention. Il faut faire très attention et par rapport au nombre de cas, mais également par rapport à l'environnement dans lequel nous évoluons. La première chose sur laquelle je voudrais insister, c'est que hier, nous avons eu la réunion du comité de crise et urgence sanitaire sur l'approche One Health, sous la présidence du ministre d'État en charge des Finances. Je voudrais exhorter mes collègues de veiller à associer le ministre des Finances vraiment à tout ce qui va être fait. C'est fondamental vraiment parce que nous savons que le nerf de la guerre, c'est les finances. Le deuxième point d'attention, c'est par rapport vraiment à la santé communautaire. Si nous voulons vraiment procéder vraiment à l'identification rapide et à la notification des cas, il faudrait que nous puissions avoir des systèmes de santé communautaire bien robustes. Et je pense qu'aujourd'hui, le Bénin, avec sa nouvelle politique, se sent beaucoup plus à l'aise par rapport à l'identification et à la notification des cas. Le troisième point d'attention sur lequel je voudrais insister, c'est vraiment le système de diagnostic. Avec la COVID-19, nous avons eu 14 laboratoires au Bénin qui ont été activés par rapport à la PCR. Aujourd'hui, avec l'urgence qui a été déclarée, nous avons activé 4 déjà, étendus sur tout le pays, pour commencer, quitte à ce que par la suite, les 14 soient activés. Mais le défi réel réside au niveau des réactifs, bien sûr, qu'il faudra mettre en place au niveau de l'ensemble de ces laboratoires et vraiment au renforcement de capacité des ressources humaines. Vous savez, nous avons un défi aujourd'hui. Quand j'ai regardé tantôt la question de la vaccination et j'ai vu le ministre, mon cher ami et frère de la RDC présenter, j'ai eu froid dans le dos. J'ai eu froid dans le dos parce que lorsqu'il a présenté les cibles pour la vaccination, les cibles prioritaires, je me suis dit déjà, même les agents de santé ne seront pas couverts. Et j'ai eu peur. J'ai eu peur parce que quand je regarde les doses de vaccins qui sont disponibles aujourd'hui, les capacités de production, la priorisation par rapport aussi priorité à l'intérieur des pays, mais également à l'environnement. Quand je prends le Bénin, quand on parle du Nigeria, on parle du Bénin, hein, on ne se trompe pas. Quand je regarde ça, j'ai froid dans le dos. Est-ce que nous n'avons pas suffisamment tiré le son de ce qui s'est passé au cours de la COVID-19? Je me pose des questions. Et c'est pour ça que vraiment je voudrais nous exhorter par rapport vraiment à ce que nous puissions faire en sorte que cet accord, que nous puissions y parvenir rapidement, mais que nous puissions également tirer le son de tout ce qui s'est passé au cours de la COVID-19 pour vraiment arriver à enrayer rapidement cette nouvelle crise sanitaire qui est déjà là et que nous avons à gérer. Je vous remercie.
Monsieur le Minister, over to you.
Thank you very much. I just wanted to thank again the member state that intervened and share information with us, and also those on the high table with the response that were already given. Just wanted to add a very humble and modest contribution. First, we talk a lot about the vaccine and vaccination because it is very important and it is a powerful tool to stop outbreak. Here, we all know that the quantity of vaccine is not sufficient, and likely it will not be sufficient for the next upcoming month and even maybe years. And I do believe that we should be thinking about strategy to deal with that fact. It is a fact. It is something that we can't change. And the strategy that we suggest to all member states to think about today and also to work with our country office is first, the vaccine should be very targeted. It should target the contact. It should target community that are clearly defined to be at risk, but also to have infection in their community. Because it's not only because they are at risk that we're going to vaccinate them. For example, if we take the children under 17, in many countries, it's over 30% of the population. We can't vaccine them with the quantity of vaccine we have. We can't vaccine them with the kind of vaccine that's going to be manufactured for the upcoming years. The second aspect I wanted us to take into consideration is that we can discuss vaccine, but we should not forget the other public health measures that can control outbreaks. We have many other public health measures that had control outbreak before vaccine exists, and that still can control outbreak without the vaccine. I'm talking about surveillance. I just said during our previous presentation that the integrated disease surveillance and response in Africa had improved in an incredible way for the last couple of years. From 21%, it is at 80%. We can build on that, use that integrated disease surveillance. The polio surveillance, many countries that are at risk at mpox have also polio surveillance. Hundreds of people, medical doctors, are doing surveillance there at the community. 100,000 of people, of vaccinators of polio are being trained. They should be used for the surveillance, for the community surveillance. Case management. When you detect early, thanks to the surveillance cases, and you treat them very early, you're going to reduce the transmissibility. The time that that patient would have been transmitting the disease will be reduced to very slow, to a couple of weeks. Otherwise, it may go maybe for months. And also, finally, the communities can stop the outbreak alone. So if you inform them, give them the minimum that they are asking, they can stop it alone. So in conclusion, I would like to say vaccine is important, but it is not everything. In particular, the quantity is not enough. Let's target it. And also let's use a lot the other public health measure. Thank you very much.
Thank you very much for that very valuable intervention. Indeed, as my sister, the Honourable Minister from Uganda, Jane, spoke, it reminded me of the fact that HIV/AIDS, we have dealt with, many of your countries have dealt with HIV/AIDS, and yet we don't have a vaccine, but we have done it with the basic public health tools. We have done it with diagnostics, with testing, with therapeutics, and with, Public Health 101. So that was a very important message. Thank you also from Benin. Next, I go to Chad.
Merci, Madame la Présidente. Merci, Madame la Modératrice. Je voulais juste faire quelques petits points par rapport à la situation de la variole dans notre pays. Je voulais remercier d'abord l'OMS pour la mise à jour essentielle que nous avons eue sur la situation de la variole, connue sous le nom de mpox. Nous saluons les efforts continus de l'organisation pour suivre l'évolution de cette maladie et fournir au pays les informations nécessaires pour se préparer efficacement. La République du Tchad, bien que n'ayant pas encore enregistré de cas confirmés de mpox, reste vigilante et engagée dans la prévention et la gestion de cette maladie. À ce jour, 58 cas suspects ont été signalés, testés négatifs, et ce qui témoigne de notre vigilance et de notre capacité de diagnostic grâce à notre laboratoire de biosécurité des épidémies d'Anjamena en collaboration avec l'Institut national de recherche biomédicale de Kinshasa. En termes de prévention, un comité ad hoc chargé de suivre les interventions concernant les cas suspects, de mieux coordonner les actions de préparation et des communiqués ont été diffusés à l'attention des acteurs de la santé et de la population pour renforcer la sensibilisation et la vigilance. Bon, je n'oublierai pas de dire que le plan de réponse et de préparation est élaboré, que nous restons résolus à collaborer avec l'OMS et les partenaires pour renforcer notre soutien pour protéger notre population. Je voulais juste faire 2 ou 3 remarques à l'intention du DG, Dr Tedros, par rapport à l'accouchement de sa fille, lui dire que le bureau africain de l'OMS, nous ne pouvons que le remercier pour tout le travail et le soutien continu que nous obtenons de ce bureau africain, malgré la naissance de la fille du docteur Tedros, et que nous, en tant qu'État membre, nous ne pourrons que dire merci à AFRO, bureau régional et ses extensions au niveau de nos pays, avec l'appui apporté à nos ministères de la Santé en termes de préparation de riposte aux épidémies, de renforcement des capacités, en termes de préparation, en termes de renforcement des systèmes de santé, de lutte contre la mortalité, appui à la couverture vaccinale et j'en passe. Le principal partenaire de notre pays, Monsieur le directeur régional, restera le bureau régional afro de l'OMS. C'était juste une petite parenthèse et souligner à la présentation que j'ai vue faite par le CDC Africa, aucun partenaire ne peut conduire ou ne peut diriger une action quelconque au niveau du pays. Donc n'oubliez pas le ministère de la Santé quand vous me dites qu'en matière de préparation c'est l'OMS, en matière de communication c'est l'UNICEF. Non. Ce sont nos ministères de la Santé qui le dirigent. Et c'est au ministère de la Santé de prendre le lead. Donc ça, il faut que... Et surtout, quand vous établissez vos priorités, il y a un point que vous avez oublié, c'est le financement. Le financement est très important pour mener les activités que vous avez listées. C'était juste une petite parenthèse à l'attention du CDC d'Atlanta et rappeler au Dr Tedros que les bureaux régionaux de l'OMS, les 6 bureaux régionaux de l'OMS font un travail extraordinaire et je pourrais parler pour le bureau régional de notre région africaine. Donc, je pense que vous avez dû faire votre intervention en tant que ministre des Affaires étrangères à l'époque où vous n'aviez pas la direction de l'OMS. Donc, j'avais espéré que ce que vous aviez suggéré avec la création de votre fille, qu'elle ait fait une fausse couche avant son arrivée. Merci, Dr Tedros.
Merci, Monsieur le Minister. Merci beaucoup. What I'm going to do is I'm going to go next to Senegal and I'm going to take, yes, I have I think they're sending me cards, but I have Sierra Leone coming up next, and then we will take, we'll take a couple of comments and do the questions in batches. If I could please request ministers to, direct questions specifically to our experts and to DG and RD and Africa CDC, that would be great. Thank you very much. Sierra Leone.
Thank you, Madam Chair. I want to start by really thanking the DG and all of the speakers today. I was really impressed by the continent-wide preparedness and readiness that was shared. But I also just want to reiterate that continent-wide preparation is only as good as local preparation. A case in point for us is last Friday, we saw a case that was clinically, just all aspects of it looked like mpox. The test results came back negative from multiple labs. We're concerned that perhaps the primer was too targeted for what we were seeing. And so for us, the issue now is we send those samples to other labs in and out of the continent for confirmation or for investigation. How long do we have to wait for results to come in to get us better educated? I think, as you said, you want to localize some of these capabilities and capacities. I think in Sierra Leone, we're yearning for the ability to have labs that are capable of helping us with local diagnosis. Again, we don't want to squander this opportunity of having seen what others are doing and wait till this turns on its head in our country. So I would ask that as we move forward, we truly mean what we say. We're praying hard for the vaccines and the chemical countermeasures, but we know that prayer is not a strategy.
That's right.
And we will do, in the interim, epidemiologic control based on either confirmed diagnosis or very strong suspicion. We ensure that we could isolate, we could do contact tracing, we were able to contain it locally as we wait for solutions. But none of this is going to be helpful if we don't have the lab capabilities and capacities. I'll ask for that to be a priority for this organization. Thank you.
Thank you very much, Minister. I'm going to take a question now. I'm going to give you an order for the next batch of questions because we really are running out of time. I have Zambia next, Rwanda following, Ethiopia, Central African Republic, and Senegal. I go to Zambia.
Yeah, so mine, or for Zambia, it's largely comments. And basically, we thank everybody for the urgency they attach to this mpox. This is demonstrated through the declaration of the emergency by both the World Health Organization and the CDC, the development of the costed 6-month plan, the response framework of one plan, one budget, and one monitoring plan, and what I call the whole of Africa approach. I'm slightly worried about coordination, but I'm glad that it was said that at continental level, coordination will be done both by the CDC and the World Health Organization. But it's just nice to delineate how this is done so that implementation is seamless. And the faster that's done, the better, so that people are clear in terms of who plays what role. In fact, this also helps donors to direct resources in an optimal way. Yeah, I do not need an answer to this. I just wanted to speak to that. At national level, it's slightly easier. We mentioned entities like UNICEF, USAID, American CDC, and so on, doing several other things. It's easier at this level because people will be buying into national plans, but I still also think there is need to do a bit of work even at that level, because sometimes things even which are going to be implemented at national level might be predetermined at levels that are above the country. For example, money is thrown into a third-party entity to implement activities in that country without necessarily having a dialogue. And on the science, and I'm just curious, it looks like mpox is on the rise, and my question would be that based on existing data and related to what has happened to this disease and similar diseases in the past, are we not able to determine the worst case scenarios using modeling, which would then inform interventions and the resources that we will need subsequently for that. Finally, I have a question just related to the pandemic treaty, and it's around the things that we are not agreeing on. My question is that, are there things that we as Africans are also not agreeing on, or the disagreements are just between ourselves and the people that we are negotiating with from the developed world? Thank you.
Thank you very much. I do urge you all, I'm so sorry, we are running out of time. I'm going next to Rwanda and then to Ethiopia. Please direct your questions specifically, and our experts are available outside during lunch for bilateral discussions as well. Rwanda, please, then Ethiopia.
Thank you, moderator. Rwanda has withdrawn its request for speaking for the purpose of time. Thank you.
Thank you. Thank you very much. Ethiopia.
Thank you very much, moderator, and I'll be very brief. We wish to thank all the presenters for the excellent and very informative briefing on mpox and updates on the INB. We're very pleased to see the positive partnership and collaboration between WHO and Africa CDC to meet the needs for the continent. In light of the ongoing risk in the neighboring countries, Ethiopia has scaled up its preparedness efforts, including through surveillance and border health measures, among others. Excellencies, distinguished delegates, the mpox outbreak is a stark reminder that we're still not prepared and live in an immense and imminent risk for another pandemic. The pandemic agreement negotiations have touched upon the very critical areas to finding lasting solutions to the challenges of numerous outbreaks that our region is facing. These include areas of pathogen access and benefit sharing, financing, logistics and supply chain, local manufacturing, research and development, and transfer of technology, among others. We all need to keep the momentum with a great sense of urgency and seize the generational opportunity through the pandemic agreement negotiations for building a safer and healthier world. The INB negotiations, starting in 2 weeks, will determine the pace for having the legally binding international instrument and finalize the agreement before the end of 2024. As agreed during the ministerial meeting held in the sidelines of the 77th World Health Assembly. To this end, it will be important to leverage the political and diplomatic communications with other member states and stakeholders to ensure the operationalization of equity and global solidarity. Ethiopia remains steadfast in its commitment to finding multilateral solutions and building resilient health systems. I thank you.
Amaseganalo, Central African Republic.
Merci, Madame. Je vais être très bref. D'abord, retirer les félicitations à l'OMS et à Africa CDC pour cette séance de communication très efficace et qu'il faut systématiser. Il ne faut pas que sur les épidémies, les communications soient événementielles. Que ça soit une manière de vivre, parce que, comme l'a suggéré M. Kasseya, le docteur Kasseya, il y a des choses dont on doit être informé très vite afin de nous aussi relayer la bonne réponse au niveau des communautés. Hein? Donc, moi, je suggère qu'il y ait je n'ai pas encore vu une relation avec les ministres. C'est nous, les ministres, au niveau des pays, qui sommes les chefs de file. Et vous travaillez pour nous appuyer. Je n'ai pas encore vu cette organisation de travail avec une communication soutenue avec les ministres. Donc, je demande que quelque chose de ce type soit mis en place, soit par des réunions régulières, soit en ligne, couplé éventuellement avec une sorte de bulletin qui nous donne de façon avec des boulettes, des choses que nous devons retenir tout de suite, sur lesquelles on doit être alerté. Je voudrais également insister sur la question de la communication en direction de la population. Nous, on a eu une épidémie urbaine, mais j'ai communiqué directement avec la population. J'ai convoqué tous les chefs, j'ai parlé avec 500 chefs de Bangui directement. Je leur ai présenté la situation de mpox en détail. Ça suffit pour mobiliser toute la communauté avec les agents de santé communautaire et circonscrire l'épidémie. Donc, les médias seuls ne suffisent pas. Il faut que les ministres montent au créneau, rencontrent les leaders directement, prennent leurs questions, répondent à leurs questions,
présente les détails. Les populations aiment aussi des informations scientifiques. Donnons-leur les informations scientifiques. Ils ont beaucoup de questions dans la tête. Et prenons-les au sérieux. Ça, c'est un point extrêmement important. Je voudrais insister sur la question qui est relevée par le directeur général de l'OMS, mon frère Tedros, dont je suis très fier, parce que pour la première fois, il a mis le doigt sur un point que nous connaissons tous, mais nous mettons la tête dans le sable. C'est la paix, la question de la paix et de la guerre et la santé.
Merci.
Nous devons l'aborder de façon directe, ouverte. Et je ne sais pas pourquoi ce comité ne fait pas de déclaration sur cette question qui nous affecte tous. C'est un point extrêmement important, il faut en parler. Et c'est là que l'Union africaine a un rôle à jouer. C'est là que Dr Kasseya a un rôle à jouer auprès des chefs d'État pour prendre les données, les évidences et dire voilà la guerre, voilà les données. C'est ça. Et moi j'insiste là-dessus, Dr Tedros, Dr Kasseya, Dr Moeti, parler des problématiques de la guerre et tout. On doit le faire. Sinon, on passe à côté. Et c'est de là que la question de la politique et de la santé revient, nous rattrape. Je voudrais enfin finir par le problème de la collaboration. Je félicite aussi l'OMS et les Africa CDC pour cette démonstration d'une recherche de la cohérence, de la coordination, de l'efficacité, d'un travail d'équipe. Mais dans la collaboration, le leadership collaboratif, il y a trois choses que je voudrais retrouver. D'abord, il y a une vision. Vous avez un plan. Je crois que ce plan doit déployer une vision commune. 2, vous avez des processus, des outils communs, des procédures communes. C'est ça la collaboration. Je n'ai pas encore vu très bien comment ces outils, ces processus, ces outils communs sont en place. Et ça rejoint ce que mon collègue de la Zambie a dit, comment cette collaboration se passe. Il faut le décrire. Comment la complémentarité joue. J'ai vu les divisions de travail qui sont très très génériques, qui n'ont pas de dents, où il y a encore des risques de chevauchement. C'est ça qu'il faut, on doit éviter.
Merci.
Pardon, dernier point. Oui. Dernier point, j'ai parlé des processus, mais je parle de comportement. On peut avoir un bon plan, on peut avoir des outils communs, mais notre comportement détermine tout. Ce sont les hommes qui mettent en place les plans, qui utilisent les outils, et notre comportement compte. Et observons nos comportements, faisons l'effort tous les jours de nous supporter, de travailler ensemble, de se dire la vérité. Voilà ce que je voudrais dire, madame.
Merci beaucoup. Thank you very much. Yeah, some very important points there. I'm going to go straight to Senegal and finish with, Côte d'Ivoire. And then we will go to the panel for their responses. Senegal, you have the floor.
Merci beaucoup. C'est juste pour partager notre expérience du Sénégal en matière de riposte et remercier l'OMS et CDC pour cette initiative et dire que nous, on a, dès la déclaration de la pandémie, nous avons travaillé en étroite collaboration au niveau sous-régional avec l'OMS, l'OAS et l'Institut Pasteur qui ont eu à faire un partage des dispositifs et des protocoles qu'il faudrait mettre en place pour envisager la riposte au niveau national. Et cela nous a permis de développer un plan de riposte avec le Comité national de gestion des épidémies. Et dans ce plan, on s'est dit qu'il faudra promouvoir l'approche communautaire parce qu'il faut faire de la surveillance une affaire de tous pour mieux impliquer les populations pour arriver certainement à détecter des cas de manière précoce. Et dans ce plan de riposte, nous avons développé un plan de communication parce qu'on a dit que le premier pilier qu'il faudrait mettre dans un pays où on n'a pas encore eu de cas, c'est le plan de communication qui a mis l'accent sur les causes de la maladie, sur les symptômes, sur les facteurs de risque et sur les moyens de prévention. Parce que pour nous, il est important que les populations et les communautés les comprennent très bien, même en langue en langue nationale. Et l'objectif que nous avons visé à travers ce plan de communication, c'est amener les populations à comprendre les gestes, les comportements et les attitudes en l'absence de cas. Comment faire pour qu'il n'y ait pas de cas? Parce que pour nous, c'est extrêmement important que ce soit très bien maîtrisé dans ce sens-là. Maintenant, on a aussi développé un plan de communication au cas où nous avons des cas. Quel doit être le comportement, les réflexes et les attitudes de la population pour limiter la propagation de la maladie et aussi comprendre les modes de prise en charge qui existent et comment faire pour guérir les cas de manière, pour avoir une réponse précoce qui pourra vraiment limiter le développement de cette pandémie. Donc c'était ça des éléments de contribution par rapport à notre expérience jusqu'à ce jour-là et dire que nous n'avons pas encore eu de cas, mais on est en train de faire la surveillance avec des tests qui sont mis à jour à chaque instant. Merci beaucoup.
Merci beaucoup. Côte d'Ivoire, please, last but not least.
Merci, Madame la Présidente. Je voudrais remercier donc la table de séance pour les informations utiles données donc ce matin concernant la maladie de la variole de singe, mais en même temps donc tous les progrès réalisés sur les négociations pour le traité pandémique qui va être un outil efficace pour protéger nos pays. Alors en Côte d'Ivoire, nous avons notifié notre premier cas de variole des singes le 2 juillet dernier à partir d'un seul cas. Et là où nous devons montrer l'intérêt donc d'avoir vraiment un système qui intègre tous les ministères et tous les services, c'est que à partir de ce premier cas, nous avons eu donc plusieurs cas, surtout quand nous avons renforcé donc la surveillance au niveau des districts répartis à travers tout le pays, avec plusieurs notifications de cas suspects qui est autour de 272, mais les tests ont donné 32 cas confirmés et un décès donc, avec un malade qui avait des antécédents donc, de VIH et de toxicomanie. Aujourd'hui, donc, sur les 32 cas, il y a 12 qui complètement guéris et nous suivons donc, nous accentuons la surveillance au niveau donc, de tous les districts. Le taux de positivité qui était dès la première semaine de 90%, lorsque nous avons commencé donc, les premiers cas suspects, est passé la seconde semaine à 30%, et les 2 dernières semaines, nous avons enregistré 0% donc, de positivité sur les cas suspects. Ce que nous voulons dire, c'est que nos cas sont issus d'une mine où les premiers cas détectés n'ont pas pu être pris en charge correctement alors que nous avons mis des directives et nous avons instruit nos services à le faire. Donc ça nous amène à voir comment, au-delà du secteur de la santé, nous devons agir avec nos collègues des autres ministères pour que dans les RSE des entreprises, des dispositions soient prises pour vraiment protéger nos populations. Donc on a eu des cas de contamination groupée à partir de cette situation-là. Également, ça a été déjà dit, la difficulté que nous avons, c'est que pour le personnel de contact, le personnel soignant, on a eu, c'est vrai, en plus de la protection que nous leur donnons avec les épis, mais les gens ont besoin quand même qu'ils soient protégés. Et on avait espéré donc avoir au moins les premiers vaccins pour protéger donc ce personnel-là. Jusqu'à maintenant, ce n'est pas le cas. Merci beaucoup.
Merci beaucoup, Monsieur le Minister. I am going to go very quickly to Professor Precious Matsoso, who's going to speak very quickly to the question about the pandemic agreement.
Thank you very much. In response to the question raised by the Minister of Health of Zambia, I wish to confirm that yes, in the Africa region, there is an Africa common position which was adopted by the health ministers, so there is no problem within the Africa region. But in addition, there are also cross-regional formations where groups of countries agreed, for instance, the Group for Equity or the Group for One Health, they have common positions, even if it's across different regions. So I think the principle here is to get all of them to converge towards one position. Thank you.
Thank you very much, Precious. And Dr. Moeti, a few final comments.
Thanks very much, Chair. I'll be very, very brief because we're very much out of time for this session. First, I'd like to thank all the honorable ministers, the delegates for your observations. I would like us to thank and recognize one person who's been very instrumental in our negotiations on the pandemic treaty at the Geneva level. This is the colleague from Ethiopia who spoke, Madam Alenkna, who has played, I'd like you to stand up. Stand up so people can see you and know that you have worked really hard in Geneva in supporting the pulling together of the position of the African countries. It's been really heroic work, and my team and I have appreciated very much the role that you've played. Just to underline that we need the replacement at the level of the Africa group in Geneva for her role. And I'll leave that in the hearing of the Honorable Ministers of Health. We need to see with the ambassadors, because this process is starting again next week. And we need a focal point who will support the discussion among our countries. We don't have that at the moment. So I'd like you to be aware of that. And we need to do something about it. It's urgent. And then for the rest, I think it's just to note the comments made by the ministers, to appreciate the very active engagement of on this issue, which justified organizing this session, and to let you know that we will find ways to continue with the conversations. So the Honorable Minister from CAR asked us, can we have regular briefing sessions? We will do our best, but I think we also need to see how we can provide through the country offices, through the WRs. I agree very much that now we know very much how to work through platforms where we are not present, in order then to see how to continue to be in contact. As long as we get the response and we can put it into the working programs of very busy people. So what we think is that when there's something very important about to happen or happening, that's when we would provide such a briefing. We have provided a briefing before. We tried to do that in preparation for what's going to be coming in the next couple of weeks, the negotiations at the global level, which I really would like to emphasize. Then finally, to say that just the exposure of healthcare workers, that came up several times. I thought that once there had been high risk or cases identified, healthcare workers were among those that were prioritized for access to vaccine. So just to make sure that that is clear to honorable ministers, we are not leaving healthcare workers to be at risk while we provide vaccine for anybody else. And then to agree very much on the comment made by the Minister of CR, that in addition to the Peace for Health initiative that we have in countries, coming out of that should be then the ability to address the drivers of a lack of peace as determinants of health, and appropriate that issue and be able to put it on the table for various leaders to be aware of and see what they can do. Thank you very much. Just asking, we had asked through that, we briefed our WRs and we've asked them to brief you about the upcoming negotiations, and we have asked that we identify a certain profile of experts to be part of the African negotiating groups. I won't go back into that, but we'll come back to you again through the WHO country offices. We're looking for certain profiles to be part of the people who are on the table, around the table on behalf of African countries. Thank you.
Thank you very much, Dr. Moeti. I want to thank all of our speakers today and all of you, honorable ministers, excellencies, for your questions and for your comments and your insights. Yesterday, you all, Africa, 14 countries raised $45 million in WHO Afro's first investment round. I want to congratulate you on that. That is a beginning, but it is not enough. We as a people must take control of our own destiny. We as a people must revisit the Abuja Accord. That was, I think it was over 22, 23 years ago now, the Abuja Agreement, where we agreed 15% of spending to health. That is what will stop us from having to go out and beg for donations for vaccines. That is what will enable us speed up and beef up our R&D industries. That is what will enable us train our health workers and ensure that mpox didn't start in 1970 and we're today just dealing with it because the world has left us behind. We cannot repeat the mistakes of COVID, but most of all, we cannot repeat the mistakes of HIV. So I want to thank you all for your attention today. I want to thank you for your spirited discussion. Our panelists have said they're willing to be here afterwards to talk to you in the corridors during lunch. We must stand in solidarity. We've heard we do not want travel bans placed on us, and we don't want to be cast aside by the rest of the world. Africa is the cradle of humanity. We are the ones where humanity started. We are the ones who lead the world. You all, the ministers, are the ones in charge of our health. I thank you all.
Okay, so, dear delegates, there are some admin announcements, please. Thank you for your attention. Please note that the special side event on tackling the public health emergency of preventable child mortality in the WHO African region will start in 15 minutes. In 15 minutes from here. Secretariat will ring a bell announcing the beginning of today's special event. Lunch is served on second floor in restaurant 1 and 2, and ministers and head of delegations are served in restaurant 1. Thank you for your attention.